And we have 3 talks for the session. And we will start with Professor Oliver Welsh. You know him quite well, I guess. Now he had a talk at the first day of the symposium. He is the Emeritus Professor, Active Coordinator of Basic Research at Dr. Jose E. Gonzalez University Hospital at Monterrey, Mexico. And his talk will be about the advances in the treatment of Actinomycetoma. Professor Welsh.
Thank you, Mr. Chairman. First of all, I want to thank again the coordinators of this symposium on Mycetoma, Dr. Fajal, Dr. Magoo, and that have been so kind with us during all these days, and had made to me and my wife very happy to be here in Sudan. This has been a unique experience for us. Well, it doesn't project. Well, meantime, I'm going to tell you that we began the study of actinomycetomas back in 1970, when I came back from my residency from the University of Michigan, where I had the opportunity of working with the mycology laboratory. It was one of the strong places for mycology in the United States at the time. And the chairman of the Department of Dermatology, his line was mycology, one of the lines of research. And all the residents had to pass the 3 years course of mycology, in which there was a practical course in which we had to do all the microcultures. If you failed that exam, you flunked, you didn't receive your diploma as resident in dermatology. So, and well, that's the story. I came back to Monterrey in 1969, and I was affiliated right away to the medical school, to the Department of Dermatology, the Department of Microbiology, and the Department of Pathology. So that gave me the unique opportunity of being in those 3 departments to have all the different aspects of that's it. Thank you. And so we're going to start again. I come from Monterrey. Monterrey is the industrial capital of Mexico. Remember that Mexico has the last census last year, we had 112 million. And the women predominate. There were more women than men, supposedly. Our metropolitan area in Monterrey is over 3 million. And that is the university hospital. It's a big campus in which there is basic sciences and and also the attention of 4 patients. The hospital belongs to the university, but it's a county type of hospital where we see patients with low income. Again, remember that the infections by actinomycetes can be the different clinical pictures, and that we are going to talk essentially to actinomycetoma's treatment. Here, I have to add Dr. Michael, his last new species, and Wendy's for my next talk, but for now, those are the actinomycetes that I had gathered causing mycetoma in men. But you can see in below some of the experiments that we have been doing with Nocardia brasiliensis in our laboratory, in which we have done testing using the blue alamar that Dr. Paul was talking about, to see the different sensitivity of different antimicrobial agents or combination of them. But here you can see how in human macrophages from the peritoneal cavity, you can see how the infection by Nocardia starts, and in a few hours they grow very much. We like to test this study in order to check how in ex vivo experiment we could determine the effectivity of different antimicrobials against this type of infection, and of course also in vivo. Here are remember that this disease is also systemic, and these are, I already presented last time, but now I'm ashamed a little bit to present it, because after being in your department, you have overwhelming amount of cases of all sizes and types. And but anyway, this is the youngest fellow that we have seen with mycetoma of the trunk, and this is our second more frequent type of mycetoma, actinomycetoma, that we see in Mexico. Perineal, very unfrequent, no, is not very common anymore. And these the experiments that we have been doing back, I will say this was done in the end of 70s, when we began studying the experimental actinomycetomas in mice. And you can see that in a few weeks the destruction of bone is quite big. This is what Dr. Salinas and Dr. Lucio Cabrera, it was part of his doctoral thesis in our medical school, which he identified 39 different antigens from the Nocardia brasiliensis that we were studying, and we selected these 2 because we thought that they were the most reproducible among all the serums that we tested against these antigens. And then was with another in another study by Dr. Salinas, was implemented as a part of a serological test that is available for us when we have a patient that has infection by Nocardia brasiliensis, and that we want to test serologically the amount of antibodies against these antigens, and see the clinical pathological correlationship. You can see in the first line, the healthy patients, the second, patients with tuberculosis, the third line is patients with leprosy, and the fourth, the patients with mycetoma that are actively sick. And you can see that it's not a cross reaction. You can see in the first line that there is one that it belongs to one of the lab technicians that was handling Nocaria brasiliensis, and I supposedly that she got anyway exposed and had some antibodies. So be careful with Nocaria brasiliensis when you are handling it. Well, what do we do with the patients in general with actinomycetomas when you have a clinical case? Well, we do very much what you are doing here. We do the direct mycological examination, culture for fungi and bacteria, the antibiogram, serology against the immunodominant antigens in case of Nocaria, and CBC, chemistry profile, urinalysis, creatinine clearance, audiometry, and radiological studies. However, when we see a patient like some that we saw this morning, we perform another tests like immunoglobulins, CD4, CD8, cutaneous reactions, candidine, trichophytine, coccidioidine, PPD, streptokinase. We perform serological studies for eliminating HIV, as well as other antigen detection of AIDS and other retroviruses. What are the important factors in the therapeutic evolution of the patients? First, the adverse effects and drug cost of the medication. Second, duration of treatment. Third, host immune status. Fourth, treatment compliance. And fifth, bacterial resistance. I think that are the most important factors that we have to take in account in order to be successful, that we have to analyze perfectly when we are treating these patients. In the left side of the, in white, you will see the different type of antibiotics and antimicrobials that were used in white until 1969-70. They were available: streptomycin, sulfonamides, DDS, clofazimine, rifampin, tetracycline, mainly minocycline, isoniazid, etc. And sometimes we have used some of them nowadays very rarely. Trimethoprim sulfamethoxazole still is available and used. Amoxicillin clavulanic acid has been useful when the patient is resistant to amikacin, or when for any reason it cannot be given, like for example in patients that are pregnant, and we give amoxicillin clavulanic acid for 6 months to up to 1 year. Amikacin, trimethoprim sulfamethoxazole, has been our most commonly used treatment, and when for some reason like allergies or any sometimes resistance to amikacin, we have switched the treatment to netilmycin, that is another aminoglycoside, with trimethoprim sulfamethoxazole. Other authors here in the African continent have used amikacin, trimethoprim sulfamethoxazole with rifampin, but we don't use this drug added to the other medications because we use it for leprosy only. We have used also amikacin, trimethoprim sulfamethoxazole, linked to imipenem or with meropenem in cases that are not responding. Moxifloxacin we have experience in vitro and in vivo, and has been used. It's a drug that still we don't know how much benefit will be obtained from it. Linezolid, we have one case that was resistant to everything and that responded, and the patient was cured, and it was a patient that had CD4-penia. So that means that they have a very low amounts of CD4 lymphocytes, and that he was not infected by the HIV viruses. Well, this patient started everything, and this is a bad photography, but I'm sorry with Mr. Chairman, but my friend in Monterrey that was at that time the chairman of the infectology department was the one that took the photography. For that reason, it's not very good. Here you can see the patient had multiple ulcerations. He had 6 grams of hemoglobin. We obtained, he had also blood involvement and the lung involvement. And we isolated from all those sites Nocardia brasiliensis. This patient, the interesting thing is that we thought that the patient was going to die because the patient was, with dyspnea, edematous, like one patient that we saw this morning, but all over. And so what we did was to look what do they have available at that time in the world, and we didn't find anything for clinical use, except we found some studies by Richard Wallace, an infectologist, in which he did some studies in his laboratory using for MICs different antibiotics against strains of Nocardia asteroides. And I thought, well, these are very close cousins, and these two bacteria, asteroides and brasiliensis, why we don't try this product that is amikacin at that time. And so it was how it began. We gave treatment to this patient. You can see here how the patient was improved in about 3 weeks of treatment with amikacin, given 500 milligrams every 12 hours, together with trimethoprim sulfamethoxazole. And the situation up to there was, well, the patient is not going to die, probably. So he left the hospital. He didn't take any other medications at all. And 1 year later, without taking any medication, we went to his home because he didn't want to go back to the hospital. He thought that we were going to charge him, with the account of the time that he was in the hospital. And so we went to his home and took this picture. So the patient was well without any further treatment. This really broke the paradigm that the treatment against mycetoma should be given for many months, even years, as treatment. So we start and we began after this case. This case was released in at the end of December 1982, and we began this the use of this in a subsequently fashion for treating the patients that were in bad types of patients. All of them very disseminated disease or that didn't respond previously to treatment. We perform everything of the studies that I mentioned before, and we have gathered this up to now 56 patients. 5 of them have less than 1 year of evolution of the disease, 28 between 1 and 5, 15 between 6 and 10, 5 between 11 and 15, and 3 between 16 and 20 years. The agents that we isolated in all of them were Nocardia brasiliensis in 48, Actinomycete maduri in 4, asteroides in 1, Nocardia species in 1, and Nocardia transvalensis in 1, Streptomyces maliensis in 1. The number of cycles of treatment, remember that cycles of treatment is 3 weeks of amikacin, trimethoprim sulfamethoxazole, and 5 weeks of 3 weeks of amikacin and 5 weeks of trimethoprim sulfamethoxazole given concomitante at the same time. Well, you can see the number of patients. 19 of them required only 5 weeks of treatment, one cycle. 15 of them, 2 cycles. 18, 3 cycles. Of these, one patient had a recurrence 2 months after finishing treatment. Another had a recurrence 2 years post-treatment. And another one had improvement, but she became allergic to amikacin and had to be stopped. In 4 patients, 4 cycles were required, and all the patients were cured except those 3 that I mentioned, why were the circumstances among them. Well, what were the audiometric results after treatment? Total number of patients, 56, and we found alterations in 11. Minimal unilateral hypoacusia, 5. Minimal bilateral hypoacusia, 4. Moderate unilateral hypoacusia in 2 patients. In 1 patient, there was a decrease in the creatinine clearance, and we have to make the arrangements in the dose, and afterwards the creatinine clearance returned to normal levels again. Here you can see a patient, 1 cycle of treatment, very active. That means in 5 weeks the patient was cured, and you can see that afterwards she was pregnant and didn't have any recurrence. We have followed this patient through years. Another 1 cycle of treatment, 5 weeks of treatment. Remember, 5 weeks, that means 3 weeks of amikacin only, and 5 of trimethoprim sulfamethoxazole. We have another. Chest is the second most common place for Actinomycetoma and Mycetoma in my country, in Mexico. And remember that this is all of those patients that I previously showed you were caused by Nocaria brasiliensis. However, this patient, a female, the cause was Actinomadure madure. In this patient, we gave 2 cycles of treatment, 10 weeks of treatment, before and after treatment. This patient was paraplegic. The patient had a mycetoma of the back, had involved the spinal cord, and he was paralyzed from the waist down. And we gave him 2 cycles of treatment. All the lesions were healed up, but the patient never recovered from his paralysis, and years later died from another the illness infection caused by his problem of paralysis that he had developed secondary to the nocardial infection. Here this patient were 3 cycles of treatment, 15 weeks, before and after. This before and after. This patient requires a special mention that had the cycles a little bit separated. That happened sometimes in our country, in my country, that the patients didn't return. And we have to obtain the amikacin. It was not an easy task because in those days amikacin was very expensive in Mexico. So we have some donations from charity groups and medical students and the laboratory that produced amikacin at that time. In this patient, after 3 months, he had a recurrence, and oh my God, I did something wrong. Can you return me? I pushed the wrong button.
No, it's all right. Okay. Don't worry. So it's a side.
Yeah.
Okay.
There.
Then you can go.
Here.
Okay.
Is here?
He's here. Okay.
Here.
Anyway.
This one?
This one.
This one,
Yeah.
okay. Okay, thank you. You can see here that the patient had surgery also, there, laminectomy in order to to release the pressure on the spinal cord. He finally was, he said, we cannot cure this patient, and he was released from his work, arrived to our university hospital, weighing 39 kilograms in a wheelchair, and we gave him netilmycin. He had become resistant to amikacin, and trimethoprim sulfamethoxazole, and the patient is cured. We have followed him for 13 years and is working, no problem to now. This is a recent case that we just published in the International Journal of Dermatology. She was, they thought after a car accident years before, she developed this mass and a lot of edema that was, and you can see in small nodules in the eye, in the external angle of the left eye. And she was going to be operated. I performed some direct mycological studies, and we saw a lot of granules, those that you see here in the screen. And we identified the granules also in a previous biopsy that was not seen by the pathologist. So that patient received the 3 cycles of amikacin, 15 weeks of treatment, and the patient is cured. Now, what was the cause of this? You know, we began this study before doing any study in vitro. All of these were clinical cases. So we had to test, well, why is this working? And so one of my students started doing some studies to see if there was a synergistic action among the different antimicrobials, or if there was not any action at all. And so what we found, you can see here, she did more than 30 different strains in which she analyzed this, and you can see that the combination of amikacin and trimethoprim sulfamethoxazole, that is in green, it was the best combination for killing the bacteria. And also we found from this study that approximately most of them, of the strains, the effect was not synergistic, was additive, and there was no antagonist effect among the antimicrobials tested. So amikacin, trimethoprim sulfamethoxazole is a very effective treatment in actinomycetomas. It is indicated in patients who have not responded to prior therapy, those with a rapid clinical course, those that affect the bone, and in those with a tendency to spread to the underlying organs. Studies of renal function and audiometry should be performed every 3 weeks of treatment when using any aminoglycoside. The therapeutic response is due to a synergistic effect and or additive inhibitory combination of the amikacin, trimethoprim sulfamethoxazole on Nocardia brasiliensis. The therapeutic response varies from patient to patient. Of a total of 56 patients, 34 required less than 10 weeks of treatment. The cure rate with this treatment was over 90%. The combined treatment. I'm going to show you this case. It's a Mason, 52 years old, from another state, about 600 kilometers from Monterrey, with actinomycetoma on the back of 9 years evolution caused by Nocardia brasiliensis. We evaluated him in 2007. He had a irregular treatment in San Luis Potosí with the drugs without achieving cure. Antibiogram sensible to amikacin, TS, and moxifloxacin. Moxifloxacin was added 400 milligrams every 12 hours to his treatment with poor compliance. The inflamed area and nodules increased in size. On July 2009, he returns with back pain, nodules, and draining fistula with a seropurulent exudate. He manifests paresthesia in his right hand and weakness in his leg. The culture, Nocaria brasiliensis, anti-Nocaria brasiliensis antibodies were positive. All the studies were under normal limits. HIV was negative. Audiometry, he had already minimal bilateral hypercussion. Normal evoked potential study were normal. The MIC show that was sensible to gentamicin, linezolid, moxifloxacin, trimethoprim sulfamethoxazole, imipenem, and rifampin. You see here the patient, and you can see here the MRI. It was very useful to see that there was a compression on the spinal cord, and he had already osteomyelitis in the T4. The therapeutic management of this case was Bactrim every 12 hours for 45 days, moxifloxacin 400 milligrams every 12 hours, netilmycin 300 milligrams every 24 hours, imipenem 500 milligrams every 6 hours, and the patient was cured up to now. He remained asymptomatic for past 18 months without any further treatment. You can see here before and after. 1 year and a half follow-up. So what are the alternative treatments of actinomycetoma? Are those that are here and in the screen. We have done studies in our laboratory against these bacteria, and you can see that most of them are, all of them are sensitive to aminoglycosides, but not streptomycin. Streptomycin, they are resistant. Beta-lactamic agents, amoxicillin, clavulanic acid, sensitive. Gatifloxacin, we have done some studies. Well, Dr. Lucio Vera has done some studies. And moxifloxacin, garenoxacin. These products are eliminated, the garenoxacin, gatifloxacin, because interaction or some of adverse effects, mainly in patients that have diabetes. There is, you can see here the DA7867. It is an oxazolidinone, and is very effective against these actinomycetes. This oxazolidinone is an agent of the oxazolidinone class being developed by Trios. The TR701 was very effective against strain of MRSA in mouse with high infection model. And recently TR701 has started experimental use in infection, pharmacokinetic clinical stage 2 without adverse effects or alteration in laboratory tests. So this is one of the products that could be potentially of good prospect for using in patients that do not respond to the common treatments. It is 6 times more potent than linezolid. The dosage is given only once daily, and supposedly it shortens the therapy. In June 2010, its use was approved for clinical phase 3, research phase 3. The DA7157 and its prodrug DA7218, they are active in vitro against Nocaria brasiliensis. That IHUJEG1 is the strain of the patient that you saw. That was the first patient that we treated with amikacin, trimethoprim sulfamethoxazole, that is registered in United States. The pattern of infection of Nocaria brasiliensis in THP1 macrophages is a new way to assess the pattern of infection in human cells. You can see here this, as was mentioned before, how the infection suddenly it goes quite easily and fills up the macrophages until it destroys them completely. The activity of all of these are presented in the literature. You can look in PubMed under Vera Cabrera or Mario Cesar Salinas or Welch. So DA7218 is active in vivo in experimental models in bulbous C mice with better inhibitory activity than linezolid. The next generation of oxazolidinones, such as DA7177 and its prodrug DA7218, could be a promising option for treatment in actinomycetoma caused by Nocaria brasiliensis. Here is one of the molecular structure of DA7867, gatifloxacin, that is not used anymore. Moxafloxacin, we have used it. Garinoxacin was eliminated from the formulary in Mexico. And let me see. I'm going to the comments and I finished. The clinical spectrum of infection with actinomycetomas, mycobacterium, and fungi can often be similar. Diagnostic procedures include isolation of the causative organism by culture, biopsy, PCR, and serology. It is convenient in actinomycetic infection to carry out molecular genetic studies for precise identification of the bacteria and to determine its antimicrobial susceptibility. There may be variations in the susceptibility of actinomycetes to antibiotics depending on the bacterium, host immunity, and the bacterial resistance in each country. Today, the combination of amikacin, trimethoprim, sulfamethoxazole has been the most effective treatment for severe actinomycetoma among us. This treatment is mainly indicated in patients unresponsive to previous treatment with a rapid clinical progression and those with involvement of bone or the possibility of spread to adjacent organs. Treatment should be administered in a continuous manner until clinical and bacteriological remission is achieved or adverse effects are detected. Therapeutic response varies from patient to patient. Of a total of 56 cases, 34 needed 10 weeks of treatment. When using aminoglycosides, I insist, audiometry and renal function tests should be performed every 3 to 5 weeks during the treatment. Thank you for your attention.
Thank you very much, Professor Welch, for a nice presentation on the therapeutics for actinomycetoma and at your place. Now we move to the next presentation, which is a joint presentation, I guess, by people that you know very well, Professor Sheikh Mahjoub and Professor Ahmed Fahal. Professor Mahjoub. And the title is The Sudan Experience in Actinomycetoma.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Mr. Chairman. Friends, that's enough for all of you. Yes. Where our Sudanese experience perhaps is the longest. I don't know. No, our fellow Mexicans are perhaps the longest. I don't know. So this is the definition of mycetoma that you all know by now, but slow, progressive, involving cutaneous, subcutaneous tissue, and ultimately bone. So this is Ali Ahoud. Okay. So, more than 44 years ago, since the establishment of Mycetoma Clinic in the ward in Khartoum North Civil Hospital, and that was established in 1968. And now it's more than 20 years, for the clinic was established by Professor Sami Jum'a and Najib Suleiman in the dermatology clinic in Khartoum Civil Hospital.